Hi. It's a great pleasure to be here. I'm really happy to be here today. And as you can tell from the introduction, I am not really a breastfeeding expert at all compared to probably many people in the room, but I'm a clinician. I do general obstetrics and gynecology care. And in the umbrella of providing that kind of care, one thing I've become increasingly interested in over the last several years is trying to help our patients breastfeed better, and also specifically within that, helping to figure out who needs the help in breastfeeding among our population. So that's a little bit of what I'm going to be talking about today. Some work that I've done looking at that with the Philadelphia population and our hospitals population, and really talking a little bit about the interaction of race and economics in that process, socioeconomic status, with a focus on thinking about how local understanding is really important to providing these services effectively to our patients compared to just having a big general knowledge about what goes on in the world. I have absolutely no disclosures. So what we're going to kind of go through today really briefly is talk a little bit about the bigger picture of race and socioeconomic status in breastfeeding. And then I'm going to spend a good bit of time talking about Pennsylvania and Philadelphia. And like I said, some work that we've done looking at those numbers in our hospital specifically. And then spend a little time talking about these questions about how do we find the patients who need the support, how can we better target interventions, and what might those interventions look like. You'll notice all three of those bullet points are with question marks, and that's because I don't have any answers. I'm sorry to say. I'm not going to give you any grand ideas about what we should be doing, but I think those are some of the questions that we should be asking to help our women breastfeed better. So I'm not going to belabor this because this data is well known to everybody in the room here, but this is CDC data as reported in the MMWR, and it just tells us what we know, that in general in this country, our highest breastfeeders are white and Hispanic women, and in general, Black women breastfeed less than white women do in this country. And socioeconomic status, again, like same source, we know that women at the lower end of the socioeconomic spectrum tend to breastfeed at the lowest rates. And as you go up the ladder in economic status, your breastfeeding rates increase. And that's for both initiation and for exclusive breastfeeding and any breastfeeding out at 12 months. And then if you really zero in on specifically the lowest income women, the numbers are frequently a little bit worse. Now, it was spoken to earlier about how the WIC data is somewhat unreliable because of a lot of misreporting of actual breastfeeding behavior that goes on in those numbers. But this is just a chart that shows some of the WIC data that was provided in the local agency report for 2017, and the numbers for either partially breastfeeding or fully breastfeeding infants in WIC populations by region in the country, and you see those numbers are really, really low. Within that report, the numbers for Pennsylvania report that only about 20% of WIC infants are reported as being breastfed. And again, that's probably an underestimate because of how many women don't disclose that they're breastfeeding for various reasons of trying to leverage the system. But it tells us that something is really not right with that population. One of the things that I think is really interesting considering breastfeeding and race and socioeconomic status is that while that picture looks pretty clear on a national level, in a lot of ways when you get down into smaller communities, those relationships seem to break down. Knowing the big picture is really important, and that data is really useful, but it probably oversimplifies a lot of relationships when you actually try to work with a specific population. When you look into the literature that's out there where people aren't just looking at big national surveys, you find that in lots of studies, it is true that overall Black women have lower initiation rates than white women, for example, but there are a lot of subpopulations where that's not true. Immigrant populations, recently immigrated populations, and there are several studies that show that expected ratio of white women breastfeeding more and Black women breastfeeding less actually gets flipped in urban populations and some rural populations in some regions of the country. Socioeconomic status does the same thing in smaller studies. Again, lots of studies show that lower income women breastfeed less, but then there are a lot of studies out there that when they've controlled for other factors, that relationship seems to attenuate or even disappear, and that suggests that those other things may be more at play than someone's actual income level. Why I think that's really interesting is because we want to know what's going on with the population as a whole at breastfeeding, but in the end, it's an individual activity or a community activity at its largest. And if we want to bring things to women that will help them be able to breastfeed better, we should be better at knowing what's really going on in our communities and who we are providing the support to and who really needs it. I think these relationships break down on the smaller level for a lot of different reasons. Number one, these categories that we use in large studies lump huge groups of people together in ways that are probably inappropriate. You know, calling a group of women on a national level Black is like so many different discrete communities that have different cultural and social practices around everything, not just breastfeeding. And likewise, race and economics in this country is incredibly linked, of course, and as we've spoken to with the issues of racial justice so far today, you know, we still have a society that's plagued with you know, prejudice and racism and even segregation still to a degree that we tend not to admit, largely in service to our unfair economic practices. And that's really linked and you can't pull them apart. But that being said, in different parts of the country and different environments, it's a very different thing to be, you know, a lower income Black woman or white woman or a rich Black woman or a rich white woman. If you're rural, you're urban, you're in the North, you're in the South. And understanding who those people are is really important. So if we're going to talk about local things, I always start with Pennsylvania because that's where I am now. And breastfeeding in Pennsylvania, when you look at the big numbers, is pretty much similar, slightly lower numbers overall, but the same kind of patterns that you see on the national level. And this is data from the Pennsylvania Department of Health, again showing race and ethnicity breastfeeding rates 2013 to 2016. And no really big surprises there, but when you break down into some smaller racial categories, and include Asians as their own population, we see that in Pennsylvania, our Asian population is actually our highest breastfeeders, followed by our white population, then our Hispanic population, and then our Black population. So it looks like overall, Pennsylvania is not that different than the rest of the country. But Pennsylvania is a huge state. We're big both in land and we're pretty big in population as well. And it's not just one population either. You know, you've got Pittsburgh over here in the west with one big urban area, and down in the southeast corner, there's a big urban area of Philadelphia. Those urban areas tend to be fairly liberal. They're densely populated. And we've got a huge swath of rural area in between that tends to be a little bit more red in its political leanings. That is why we're called Pennsyltucky. As well as Pennsylvania. And so what can I assume from the breastfeeding data of Pennsylvania? Can I assume that that data overall is going to apply to my tiny little corner down here of southeastern Pennsylvania that's one of the urban liberal pockets of the state? And I think that there's always a concern that maybe I can't. So Philadelphia is a great state. We're going to talk about, or a great city. We're going to talk about that a little bit. It's a beautiful city. We've got all kinds of good stuff. We've got the Phillies. I'm a big fan. But it's also got a lot of bad stuff going on, too. It's a big city. We're about 1.5 million people. We're the 5th largest city in the country. We're the 2nd biggest city on the East Coast. But we also have the unfortunate designation, according to census data, of being the poorest large city in the country. We've got a high poverty rate. We have a good percentage of people that live in deep poverty, being 50% below the poverty level. Lots of our children live in poverty. We have a lot of people without health insurance, whether that's our undocumented population or people falling through the Medicaid cracks. Our median income is around $40,000. That's gone up a little bit recently, but there have been many years where we've stagnated while the rest of the urban areas in the country have tended to go up. And about close to half of our households, the median income is under $35,000. So we are not a financially well-off city. So then, what do we know about breastfeeding in Philadelphia? Well, the good thing about being in an urban area where there's academic medical centers is you go to the literature and people have already studied your population a little bit because everyone's always doing research in their own populations. In general, suburban populations in Philadelphia breastfeed more in the hospitals in the suburban areas do. So I'm going to be talking mostly about the urban areas. And one thing that I found striking looking at the literature is there's stuff out there that suggests that Philadelphia women are not doing the same things as those national data would tend to suggest. For instance, there's a small study from one North Philadelphia urban hospital that showed that breastfeeding at discharge, so initiation, didn't actually differ in their population by race or socioeconomic status. And there have been a few studies done with patients of our health district, which is the term that's used for our city-run Department of Health clinics that provide general health care, but also prenatal care in some of our federally qualified health centers. And for instance, one study looking at intention to breastfeed found that low-income Black women in their population population were actually more likely to intend to breastfeed than white women, with immigrant women being most likely. Another study looking at the health district patients postpartum found abysmal breastfeeding rates, but that those rates did not seem to differ by race. So that suggests to me that something different is going on in Philadelphia than the rest of the country, and that if I want to know what's going on there, we should be looking at the women in our city really carefully. So this is Philadelphia. That's a picture of my hospital in the downtown area. For those of you that aren't familiar, the part that's Philadelphia here is that kind of key-shaped, oddly outlined area that's mostly blue with a little bit of white kind of lying on its side. The curvy thing coming down through the middle is the Delaware River, separating us from New Jersey in the east. The stuff that's mostly pink on this map up to the upper corner is our suburban areas. The little star right in the middle is where my hospital is in the city. This is an income map. This is based on census data. And what this roughly shows is that all those areas that are in the dark blue color, those are all households that are making less than $50,000 a year, or census tracts where the median income is less than $50,000 a year. So just looking at this right away, you get a pop that most of the area of Philadelphia is not very well off. There are a few pockets in Center City that are a little bit more affluent, and then a few pockets of affluence still within the city limits in the west and in the northeast, but overall we're pretty low income within the city limits. This is a slightly more shaded map and unfortunately a little bit bleaker that gives that broken down a little bit more. Again, that's the outline of Philadelphia, and you see the river there. The green dot's my hospital. This is a map, again, census data, but the lowest gray areas are households that are making less than $35,000 a year, or neighborhoods with median incomes less than $35,000 a year. And the next color up is households that are only making about $63,000 a year. So you again can see from this that large parts of Philadelphia, especially the north central area and West Philadelphia, are strikingly low income communities, and we don't have a lot of areas that are very affluent other than the immediate center city area and the west and the north of the city. So that's what our population looks like socioeconomically. What about our racial and ethnic makeup? I love these maps. I don't know if anybody is familiar with looking at these, but these are made through some department at the University of Virginia. These are dot maps based on census data, where these people at the University of Virginia make these maps where they're dropping a dot in the map for every single person counted on the census for a certain year, and they're color-coded by race and ethnicity. They do them for the whole country, and then you can zoom in on these little areas to a remarkable level of detail, and it's a nice way to get a visual representation of who's living where in your area. So you can see the color coding there, and again, this is that Philadelphia shape that I've been showing. You can tell that in our city, we have a lot of black population in West Philly and North Central Philly. And then we've got some clustered white population in the central and a little bit up the Northeast corridor. And then we have some pockets of Asian communities and some pockets of Hispanic communities. The Hispanic community is one that's been growing a lot in Philadelphia in the last couple decades. I promise we'll get back to breastfeeding in a minute, but just one more thing about how we're distributed in Philadelphia is that we are unfortunately still considered a hyper-segregated city. Hyper-segregation is a designation that you can get if you meet a certain list of criteria that I'm not going to go through the whole thing, but basically saying that your black people cluster together in neighborhoods, those neighborhoods themselves cluster, and they tend to be in urban areas, and most often that they are also areas with poorer social services. We used to be one of the worst hyper-segregated cities in the country. We're now off the top 10 list, so that's nice, but we're still not doing great. What these two maps show is kind of a representation of that. This one over here is the white racial distribution, and this one over here is the black racial distribution. And what they roughly show is that if you were in the darkest colors on the map, that those are neighborhoods where somewhere between 55 to 90% of the population is that color. So you can see on this map that we're really segregated with our white population, very highly concentrated in the southeastern corridor and then the northeast and west portions. And then our black population, we have black people everywhere in the city, of course, but they're very concentrated in the north central and western Philadelphia areas as well. Unsurprisingly, because that's how it goes in this country, we have a higher proportion of households that are black that are in poverty, but we have a decent population of poor urban whites in Philadelphia as well. So I promised we'd get back to breastfeeding. So how do we do with breastfeeding in Philadelphia? And the answer is we do okay, but not great. This is data from the Pennsylvania Department of Health, just going up to 2013. And you can see overall our breastfeeding rates were going up. We're still only at about 70% overall. And that looking at the racial breakdown of that, we're very similar to what you think from the state data or from national data in general. So no big surprises there. This is just showing our hospital, Jefferson University Hospital. We do about 2,000 deliveries a year. We're pretty low volume, but we're about middle of the pack in terms of our discharge data. This is, again, I think from 2013. I think we're doing a little bit better now that we're a baby-friendly hospital, but we're sort of middle in the pack in terms of what we're getting women out the door doing after discharge. So the Department of Health also gives more detailed information about breastfeeding in the city, and this is where I thought things started to get really interesting, is that this is data where they're linking discharge breastfeeding rates to zip codes within the city, and they're able to report basically by census tracts how much breastfeeding is going on where in the city. And what's remarkable about this is that there is an incredible range of breastfeeding in different parts of the city. We go from some portions of the city where we have a under 60% breastfeeding initiation rate to places where we have like 92%. And I mean, we're a big city, but we're pretty small for that kind of stuff to be going on, you know, and we are only like 144 square miles or something, and that we've got this much different stuff going on so clearly delineated is really striking. So knowing that we are a poor city and knowing that we're a very segregated city, I think that begs the question of like, what's going on and how is this happening? And so, of course, one of the things we think to look at is race. So this is very rough. This is not like anything's really been correlated here. But basically what I've done here is kind of outlined what was on those earlier maps that we looked at for where our racial distribution is roughly in the city. And the areas that are outlined in purple are the ones that really pop as being white majority area. And unsurprisingly, based on what we think we know about how women tend to breastfeed, it includes some of the highest areas of breastfeeding in the city. But what's interesting is that it also includes some of the low ones. That like northeast corridor going up by the river is a pretty majority white area, but it still has rates of breastfeeding that are in the low 60s, which is kind of surprising. Similarly, that central and western area that is largely African American and Black, it includes those areas with the lowest numbers in the very low 60s, but it also has some areas where the numbers are in the 70s and the 80s, so not so bad. So while it looks like there is some correlation with race in our city, it's not as clear-cut as you might think. And then looking at economic status, we kind of see the same thing. I couldn't find a good way to really overlay this, so they're just here side by side. But you can see that in the north central area and the eastern corridor that are still those low-income areas of the city, those are areas that have pretty low breastfeeding rates. But we also have some areas in West Philly that look like they're doing okay, and those are areas that are pretty poor. So similar to the race thing, we're seeing some correlation there, but it's not as one-to-one as you might think if what's in your head is that we just know that Black women breastfeed less and low-income women breastfeed less. So this made me really curious about trying to look at some of our hospital data as a small data set just to see what was going on there. So just some information about who we see in our hospital. Like I said, we're kind of low volume. We do about 20,000 deliveries a year. Our residents rotate at some other hospitals, so they get a lot of their deliveries at an off-site place. We take our patients from the inner city and from the suburbs. We have a lot of patients from South Philly, a lot of patients from North Philly, less from West Philly. Those people tend to go to Penn a little bit more because it's closer. And the mix of patients we take care of at the hospital really represents the city population to a good degree in terms of demographics. The one thing that might be a little bit skewed is we do serve a large opiate using and methadone population. We have a large methadone stabilization and maintenance population program for pregnant patients. So we have that a little bit more concentrated in our hospital compared to other places. We are an academic teaching practice. So when patients are delivering on our labor and delivery floor, about 80 to 85% of them come through our prenatal care system, which is one integrated faculty and resident practice, with the balance coming from our our family medicine group that does OB, and then federally qualified health centers and health districts that deliver through our labor and delivery. We are baby-friendly now, but the data I'm going to be talking about comes from a time when we were working to our baby-friendly designation, so we weren't baby-friendly yet when this was going on. And what we decided to do, along with one of our residents who was interested in looking at this question, was just to do a small retrospective cohort study with some of the easily available data at the hospital. We did this work in 2015, and then it took us a long time to get our act together and actually turn it into something useful. So it sounds like it's really old data, but we were looking in 2013 at all singleton deliveries from about a 6-month period. And then out of that group, we looked for patients who had outpatient follow-up within about 8 weeks of delivery, because we wanted to look at as our primary outcome who was still doing any or exclusive breastfeeding at that postpartum visit, and look at the exposures of women's insurance status and race, using insurance status as something we could capture from the chart as a proxy measure for socioeconomic status. What we found was in the 6-month window, we had 605 deliveries that met criteria. A little over 400 women came for their postpartum follow-up, and all of them did have documentation of breastfeeding status. Now, in research, it's always suspicious if there's 100% of anything. But I will say, at that time, we were actually doing a postpartum documentation on these paper sheets that simply had to be done, and you had to check the boxes. So it's actually feasible that we had 100% documentation. Now that we're in EPIC and it's not quite so hard stop-ish, it's probably our documentation has probably gone down. So I'm just going to be showing some summary data here, not everything that we looked at in this study to keep it simple, but this is basically our population demographics. When we broke that sample down into groups of women who were on Medicaid and on commercial insurance, we saw that a little under 50% of our population was Medicaid, and that there were statistically significant differences between the groups, with the Medicaid women tending to be younger, more likely to be African American, likely to have a lower educational attainment, less likely to be having their first kid, and a little bit less likely to be married. I didn't bother to put it up here, but there were other social and medical factors we looked at that did not differ between the groups, but they're not up here just for simplicity. So then what did we see when we looked at what was going on with breastfeeding by that? And when we looked at it by race, and again, I'm only presenting a little bit of the data here. I'm leaving off our Asian and Hispanic data and just focusing on the white and the black population, because that was what actually turned out to be interesting. We definitely found that in our unadjusted analysis, our black patients were less likely to be breastfeeding than our white patients were. But when we did an adjusted analysis with a logistic regression controlling for other factors like age and parity and education and marital status, that significance got lost. Our confidence intervals crossed 1, and the odds ratios say that black women are feeding less, but it's not a statistically significant difference. So that was kind of interesting, because that bucks the trend that we think we see in national data and state data. When we looked at insurance status, we got a slightly different picture. We saw that women on Medicaid were significantly less likely to be breastfeeding than women who had commercial insurance, and that significance was not lost when we adjusted for all of those other confounding factors. So even when you controlled for their age, their race, their parity, their education, their marital status, the rates of breastfeeding in the population of women on Medicaid were a lot lower than for women on commercial insurance. So this suggested that there's some kind of relationship going on here with insurance status. Less clear if there's a relationship by race, but it certainly suggested some interaction in those factors. So we did a stratified analysis, and this is what we found. That, again, overall, black women have the lower rates of breastfeeding of any group in our study, but the group with the lowest overall rates of breastfeeding at this time point postpartum was our white women on Medicaid, strikingly lower than any other group. And that while in the African American group, again, the overall rates of breastfeeding are lower, what I find very interesting is that there's not much difference within that population in the rates whether women are on Medicaid or on commercial insurance, whereas the difference between what's going on in the commercially insured white patients and the Medicaid insured white patients is pretty remarkably striking, really suggesting that there's something going on, that subgroup is the least likely group to breastfeed, and we're not really sure why. I think that this is an interesting finding because it bucks some of the assumptions that we might have if we have kind of a global understanding of what larger data kind of tells us. And if I'm going through my day in the office or talking to my patients on the postpartum floor, we're all bringing our implicit biases and the things that we think we know about what's going on with people to all of our interactions. And if I just have the basics in my head, but I don't know really much what's going on with my population, and not just me, our social workers, our lactation consultants, if we have in our head that white women breastfeed more, but we don't have in our head that white women on Medicaid breastfeed almost none, then there's a group that we might be missing an opportunity to do interventions with that actually really needs it more than we're estimating that they do. Now, this study has a ton of limitations, and it's basically completely not generalizable. It's a small study. It's a single institution. This is like hyper-local research. It's a short follow-up. We're using proxy measures compared to other breastfeeding research. But that's kind of my point in talking about it here. I don't think anyone should take what I'm talking about here with this study and go home to, you know, Southeast Wyoming or whatever and say, I really need to focus on my white women on Medicaid. Kind of the point is that when I dove down into what our population was doing, it was different than what I thought and suggested some things that we could probably learn and be doing better on as we move forward trying to increasing breastfeeding with these women. A word about proxy measures, because we're using insurance status as a proxy for socioeconomic status. That's like a quick and dirty way to do it using available medical data. That's why we used it in this retrospective study. It's what we can pull out. But I will say, I think it's actually a useful proxy measure for clinicians, right? I don't walk into exam rooms and ask my patients how much they make, and I pretty much never would unless I had a really good reason, because income is so taboo in our society because it's such a bad thing to be poor. But we always know our patient's economic status, and you can't assume that somebody is well off because they have commercial insurance. We have plenty of patients who have low-wage jobs that give them commercial insurance, but your Medicaid population, especially as we fund everything less and less and less, is always going to be the population that really is at risk and is truly low income. So the take-home message really from this is that I think we should all be looking at our own populations pretty closely so we can understand what's going on with them and how we can serve them. Now the question of like what's underlying this is the part where I don't have any answers, like whatsoever. Why are these groups so different? There's cultural differences. There's differences in knowledge base. There's probably lots of differences in how much support women get. We're looking at postpartum data here. We're not looking at initiation rates, but continuation. So those factors of how much support people have at home and going back to work probably play a lot into whether women are still breastfeeding at like 8 weeks postpartum. You know, these are funny little pictures here, but that kind of stuff is really the reality for a lot of women when they go back to work, as has already been like talked about today. Oh, and just something about that 8-week postpartum marker. That's not one of the traditional markers and time points for assessing breastfeeding. Again, this was a retrospective study. We were doing that for feasibility because that's a timed frame when we see women. We do know that breastfeeding for women who are going to stop drops off pretty fast after women go home from the hospital, and it's not really a thing that people stop breastfeeding and start again. So it's useful as a proxy for as good as you're going to get at 6 months was how I thought about it. If women had, these were our numbers at 8 weeks postpartum, and if women weren't breastfeeding very much, even fewer of them were going to be doing it at 6 months or a year. And then what can we do to fix all of this? I mean, this is what we're all here to try to like figure out how to do it. In my perspective as a physician and as a clinician is always thinking about what we can be doing with our patients in the timeframes that we're seeing them in their pregnancies and postpartum. And I think this is one of the things that Baby Friendly tries to get right and has helped a lot with, is that it's pushing a lot of this education into the prenatal timeframe. Even the preconception timeframe, I think, is often appropriate. But knowing that we need to start these educations and these conversations with women long before they're actually making the decision and facing the challenges of breastfeeding is really important. I think Baby Friendly has helped a lot, though a couple of people have mentioned ticking the boxes in the paperwork. And as we are continuing to be a baby-friendly hospital, I get a lot of emails about whether or not I'm filling out my charts right to help us meet our baby-friendly designation status. And I get my backup about the fact that that's because I spent the time talking to the patient about breastfeeding and not checking the boxes. And then we need to find a balance between saying we're baby-friendly and the way we actually operationalize that and being able to do it. I think lactation support's a huge part of it. As a clinician seeing women when they're coming back a few weeks postpartum, lots of our affluent patients get lots of lactation support in the outpatient setting. They're both good at knowing how to get those resources and how to access them, and they have money to pay for them if they're not supported. And it's a lot less common that we're seeing our minority population or our low-income women coming back with that support in place, whether they are or are not breastfeeding, either because it's not financially feasible for them, or they also just don't know where to go for help, and they're not as good at leveraging the system. And I think we could be doing a lot more to make WIC be a breastfeeding support system for women. I think everyone here knows that. I think that is what WIC wants to do. I think lots of our patients don't see it that way, and we could be doing a lot more prenatal education, helping women understand that that's a resource for them that can help them breastfeed, not just help them when they can't breastfeed, which I think is how a lot of them see it. And now, just a plug for making sure that we're being compassionate to all of our moms. The Fed is best movement came up over lunch, and I am in no way saying that like Fed is best by any means, and I do not like that phrase either any more than anyone does. But we all know, as we've talked about today with our representatives conversation, the reality and the fantasy about what you're going to be doing when you're breastfeeding and parenting is very, very different. And you know, as our social and political climate lurches rightward, I don't think that stuff's going to get necessarily any better anytime soon. And so a lot of our patients who have the best intentions come face to face with this and can't handle it. And then there's lots of patients who can't breastfeed medically, and there's a lot of patients who don't want to breastfeed. And as somebody who really wants to promote breastfeeding and thinks it's important and I want to help my patients, I am also faced by those patients that just say, no, I don't want to. You're like, okay, great. And then at every one of your prenatal visits, I'm going to talk it up and talk to you again. They're like, no, I don't want to. You're like, okay. And there's a certain point where that conversation is going to kind of end. And we've had patients who either are choosing not to or cannot breastfeed in our postpartum floor since we've been baby friendly. Our nurses, God bless them, really love the Baby Friendly initiative, and they want to do this right. And I've had patients come back and say, the nurses would not stop talking to me about breastfeeding, and it made me feel terrible, and I hated it. And we need to like find a balance where what we're doing is supporting our patients' autonomy and helping them like make the choices that are right for them, but also acknowledging that some women, this isn't going to like be what they need to do. But making it less scary, making them prepared to deal with it when it happens, and you know, making sure we know the patients to the best of our ability, that we are thinking about the patients who most need the help and helping them get it when they need it. And that's pretty much it. And just thank you to some of the people who helped me with our research projects. So. This one here, this one. Oh, this is I'm just going to plug this Tumblr. I'm not like an internet Tumblr-y person, but this website called It's Like They Know Us is this fabulous Tumblr of like aspirational parenting pictures and people commenting on them, and it's lovely.
Hi, Lori Winter. I'm a pediatrician, and I work at Cooper Hospital.
Oh,
right?
Hello.
Neighbor. I learned from my friends at the Rose Foundation that problems within the community have solutions that lie within the community. And so I have two questions. One is about the white women on Medicaid and whether you looked at the rates of substance abuse and narcotic abuse in particular among that population comparison to the other populations, if that was a problem that seemed to be in higher prevalence in the white Medicaid population.
It would not surprise me if it is.
Maybe that's why they weren't breastfeeding or maybe discouraged to breastfeed even though if they're in MAT, they can.
Yeah, we didn't look at it in this study. I would not be surprised if it is either as a direct effect of the substance use or because of perceptions about it. I will say that we do support breastfeeding for our methadone moms and absolutely who are in maintenance, but there are a lot of women who are very hesitant to do it with that. So we didn't have the numbers to really look at that with this study, but we do have other projects ongoing with the baby-friendly data that is looking at that. And we have had some initiatives in the hospital and especially with our NICU to try to more aggressively support breastfeeding for those moms, especially when their babies are doing like an NAS, like a withdrawal protocol as well.
Great. Yeah. And my other question had to do with the community and whether there were more support programs, whether they are WIC programs that are providing postpartum support, or baby cafes, or La Leche League, or whatever other community-based support programs, are they sort of disparately arranged around the city? We have none in Camden.
Yeah.
There's like nowhere where
That's
people
an
can go.
excellent question. I do not know of many like specific breastfeeding community-based organizations that aren't facilitated through some kind of physician's office, one of the health centers, one of the health districts. There are very few on the ground. Maternity care coalition, yes, yeah. Yeah, and I've seen more patients that are saying they're getting that support from WIC, but a lot of them are surprised, like, oh, the WIC lady wanted to talk to me about breastfeeding, and they're like surprised. Because in the patient's mind, it's the place for the formula. Yeah.